I especially thank Dr. Jyothsna, consultant ENT surgeon, for agreeing to moderate this session. I have very little knowledge in oral malignancy, so I think I will leave it to Dr. Jyothsna. I will be a eager spectator as everyone else. Thank you. Over to you,
Thank
Einass and Dr. Jyothsna.
you. Thank you, sir. Einass, please start.
Yes. Today's class is on oral malignancies. Here we'll be reviewing the various types of oral lesions, which will include
No,
the benign and malignant
Siraj?
lesions, the potentially malignant disorders, the normal variants that are there, and along with that, how do we go about looking at the risk factors, the diagnosis of the in case of oral malignancies. Uh, First, going to the anatomy of the oral cavity. The oral cavity is it's a complex anatomical space which is basically divided into two specific regions. One is the vestibule, and the other is the oral cavity. The vestibule is delineated by the so anteriorly you will have the inner aspects of the lip, the laterally the buccal mucosa, which is basically the inner cheek, and the medially you will have the labial and buccal aspects of the teeth, and the gingiva, which will be present medially. And furthermore, in the the oral cavity is demarcated by the inner oral gingiva of the maxillary and mandibular processes anteriorly. The roof is superiorly, or the roof is formed by the hard and soft palate. The floor of the mouth and the anterior two-thirds of the tongue are present inferiorly, and the posterior boundary of the oral cavity is defined as by the palatoglossal arch. Here, the first image is showing the parts of the vestibule wherein the margins can be delineated, and the second picture is showing that of like the anatomy of the oral cavity. Majority of the oral mucosa is surrounded by stratified squamous non-keratinized epithelium. This is basically lining your inner lips, cheek, most of the soft palate, and floor of the mouth. The keratinized mucosa is present over the remaining gingiva, the hard palate, and a portion of soft palate. Further, going to the variants, like there are various normal variants which are present for the.
Yes.
Yes, ma'am.
Yes, just a second. So
Yes,
you
ma'am.
explained all the anatomy of the oral cavity. So
Yes.
what do you think is the clinical importance of it? Like, is there any lesions which are more present in the tongue, or like in the buccal mucosa, or how is the anatomy more relevant with the cancers or pre-malignant conditions? Can you
Uh,
explain?
Ma'am, like you can have like the potentially malignant disorders, like leukoplakia is a condition wherein which can more likely be seen over the buccal mucosa, ma'am.
Okay.
In that way, like that is how it is significant, ma'am.
Okay, I can explain it this way, which is better. So,
Yes, ma'am.
all this, I know we are still yet to talk about the pre-malignant conditions. So, whatever the carcinogen or the potential etiology is exposed, for example, in the Western side, they usually smoke, correct? So, because of
Yes,
the
ma'am.
smoking, mostly the tongue and the floor of the mouth will be involved. Whereas coming to the Asian part, like Southeast Asia, like our India and Pakistan, everywhere, where they have like quid or the betel nut chewing or pan parak, all these things are there. Generally, the buccal mucosa is mostly involved. So, depending on how the etiological factor is exposed, that particular site will be involved. And you rightly explained regarding the different parts of the oral cavity. Now we are going to the normal variants. Please continue, Einass.
Yes, ma'am. Going to the normal variants, you have the first we have leukodema. Leukodema is basically a benign mucosal change. This is presenting as an asymptomatic bilateral like mucosal alteration, which is usually grayish white in color. And the feature here which we can see is that it will disappear if the mucosa is stretched. And it is assumed to be caused because of accumulation of fluid within the epithelial cells of the buccal mucosa. And it is a common condition which is seen, but more affecting the African American individuals. The next one is the Fordyce granules or Fordyce nodules. These are basically ectopic sebaceous glands, which are around like 1 to 2 papules, which are symmetrically distributed along the buccal mucosa. And their appearance may range from white to yellowish in color. And the third one is the physiological oral pigmentation, wherein it is commonly seen in darker skin types, and it usually occurs because of an increased melanocytic activity and melanin production. And the presentation of these pigmentations will be in the form of a brownish gray band, which will be seen close to the gingiva, and usually it is bilateral. Uh, Here are some images which can, the first image which is showing leukodema, which is appearing as a grayish white semi-transparent patch. The Fordyce nodules, which are like discrete papules, which are yellowish in color. Again, the second image, which is showing Fordyce granules. And the final image is showing physiological oral pigmentations, which is close, like the brownish bands are closely seen close to the gingiva. Going ahead to the benign lesions, the benign lesions there are various types which can be present, amongst which the first one is morsicato baccarum. This is usually a condition which is seen because of habitual cheek biting or tongue biting, which is in some cases. And this presents as a macerated, thickened plaque with fragments of epithelium. And this can be partially removed. And these lesions are typically more in proximity to the surfaces of dentition. The second is frictional keratosis, which is a white lesion, and it develops in areas which are subjected to chronic trauma, which could be the retromolar pads and the supposedly the edentalis alveolar ridge. And if there are like ill-defined, ill-fitting dentures, all of these can contribute to the development of frictional keratosis. And these are white lesions which cannot be removed. The third one is uh, in the third condition, you can see white sponge nevus, wherein again these will be whitish appearing nodular structures, which can be seen over the buccal mucosa. And these uh, these have rarely been implicated with the potential of being malignant. So, and it is basically white sponge nevus. It is sort of like a rare autosomal dominant disorder, which is present during childhood.
Just to add on to these things, if you can go back, yeah. So
Yes.
coming to this habitual cheek biting, so how do you actually come to a clinical or pathological diagnosis? Is when we take a biopsy, there will be a bacterial layer and an inflammatory cells layer. So that is one of the main features of this. And frictional keratosis, again, there will be acanthotic sites. And white sponge nevus, like clinically only, there will be like whitish layer actually, which will be resembling like candidiasis. But the thing is, the candidiasis will come off, but this does not. And yes, as you rightly said, this is a autosomal dominant disorder, and history of family history will be present, like one or two ancestral like history will be there. Carry on, Einass.
Yes. There are a few images. The first one is showing the cheek biting, which is showing the presence of a macerated white thickened plaque. Frictional keratosis of the gingival mucosa in the next image. Going to the infections, infections can occur in the form of oral candidiasis, which is a common opportunistic infection, and oral hairy leukoplakia. Uh, in oral candidiasis, it is usually caused by intraoral commensal yeast, and they can present in three forms, one of which being pseudomembranous candidiasis. This is our oral thrush. Here, it is the most common form, and it is present with white patches or plaques, which can be wiped off with which can be easily wiped off, and in most cases, they are asymptomatic. Other relatively uncommon forms include hyperplastic candidiasis, which most commonly is involving the labial commissure, like basically the dorsal aspect of the tongue. And the finding here is that these hyperplastic lesions cannot be wiped off. Erythematous oral candidiasis is again a rare form which can have various presentations, which includes denture stomatitis, which is typically found in patients who are using prostheses, like removable prostheses like dentures, and they are limited to the mucosa beneath the denture. It does not go beyond that. Chronic atrophic candidiasis will be mainly localized to the dorsum of the tongue and the palate, and they will have a presentation of red patches, and they are also associated with the use of antibiotics or inhaled corticosteroids, and also with HIV infection. Uh, the other three findings, one is of median rhomboid glossitis, which is a depapillated rhomboid midline lesion which is seen on the dorsum of the tongue. Angular cheilitis, which is the inflammation of the skin and the contiguous labial mucosa. And linear gingival erythema, which is basically a brightly inflamed, well-demarcated band over the marginal gingiva. It can also be associated with like features of periodontitis or gingivitis. A few images. The first one, which is showing oral candidiasis. Then the next one, which is showing the presence of chronic hyperplastic oral candidiasis. Then the white patches which can be seen around which like over the denture sites, which is the denture stomatitis. Depapillated rhomboid lesion over the tongue, which is the median rhomboid glossitis, and angular cheilitis, which is extending from the inflammation. Basically, there's inflammation of the skin along with the labial mucosa, and linear gingival erythema, wherein we can see a bright red band over the gingiva. The other manifestation which can infection which can happen is oral hairy leukoplakia, wherein here we see white corrugated painless plaques, and unlike candidiasis, they cannot be scraped from the surface of the skin, and they are classically seen to affect the lateral portion of the tongue, and rarely the floor of the mouth, the palate, or the buccal mucosa may also be involved. Uh, the pathogenesis behind OHL is implicated to be because of Epstein-Barr virus, which is commonly seen in patients with HIV infection or in immunocompromised patients.
Just a second, Einass.
Yes, ma'am.
So coming to the candidiasis and the oral hairy leukoplakia, the person with the OHL, they won't even know that they have it. It will be detected incidentally because it is not painful. It does not cause any problem at all. So when they go for the regular checkups, they would come across this. And this is mainly because of the EBV, as you said. Whereas the candidiasis, it's on the other side, it's not always symptomless, meaning no, there might be some sort of discomfort for the patient in terms of oral thrush, like differences in the taste or irritation or pain as well sometimes. So that is with the oral thrush, or what is like scientifically known as pseudomembranous candidiasis. Okay, now, please carry on.
Yes, ma'am. Going to the pre-malignant lesions. Firstly, in pre-malignant lesions, leukoplakia. Leukoplakia is a potentially malignant disorder which will present as white patches on the oral mucosa. And it is not a very rare condition, and the prevalence is estimated to be amongst 0.3 to 4.1%. The risk factors for oral leukoplakia being similar to that of carcinoma, which includes tobacco use, alcohol drinking, and in addition, leukoplakia has also been shown to be associated with human papillomavirus infection. The pathogen, yes, ma'am.
Just before jumping into the each condition per se, I would like to ask you these questions. What is the difference between pre-malignant lesion and pre-malignant condition, and how is it different from potentially malignant conditions or potentially malignant disorder? You have used both the terms, correct?
Yes, ma'am.
You have put the slide as pre-malignant conditions, and you were using orally potentially malignant. How do you think these two are different or are the same?
Ma'am, pre-malignant lesion will has a higher chance of getting converted into a malignancy, like in comparison to a potentially malignant lesion.
Not exactly. Any other surgical residents, senior surgical residents who can answer this?
Lesions means in that particular area there is a chance of developing malignancy. Condition means whole cavity has the capability of conversion to malignancy.
Okay. So it's not exactly that. So what happened is WHO initially, when they actually created this definition, they told like lesions such as like leukoplakia, erythroplakia. So these are the lesions which will definitely convert into malignancy over a period of time. So they call this pre-malignant lesions. Okay. So few conditions such as like submucous fibrosis or lichen planus. So these are all conditions where a larger surface area is involved. There is like pathogenesis happening throughout the oral cavity, correct? So these were called as pre-malignant conditions. However, in 2008 or so, the WHO, they said, okay, we'll not have these two conditions as a lesion and a condition. We will submerge it and we will call it as pre-malignant disorders. Okay, so they told like, the risk of malignancy being present in these lesions or conditions at the time, it may be increasing over the period of time. So that's why they call it as pre-malignant disorders. Recently, now they have taken off the definitions of all that, and now they call it as oral potentially malignant lesions. Why? Because pre-malignant conditions are like the lesions which will definitely or like will convert into malignant lesions. But when you actually clinically see, not much of them convert over it. Few of them convert, few of them don't convert. So they are calling statistically their chances of progression to the malignancy is more. So that's why they're calling in a safer way orally potentially malignant lesions. So at present, what we have to call is potentially malignant lesions. Okay, so just wanted to explain this to you because this can be a question in your Viva also. Okay, now we can go to each condition, leukoplakia and erythroplakia. And also coming to the incidence, globally, all the potentially malignant conditions, it is only around 4 to 5%. And from each place, like in the US or Europe, it can be different. They will be presenting more with the leukoplakia and erythroplakia. Whereas coming to the Indian subcontinent or the Southeast Asia, it is more of submucous fibrosis, followed by leukoplakia and everything. And you please explain later regarding each condition. Einass, continue.
Yes, ma'am. The pathogenesis. So the pathogenesis of oral leukoplakia is considered to be basically so oral leukoplakia is considered to be an intermediate stage in carcinogenesis, which could be because of various somatic genetic mutations which are affecting the keratinocyte growth, the cycle control, and the survival. All of these are resulting in histopathological and clinical modifications. Histopathological being hyperplasia, dysplasia, and hyperkeratosis, and clinical manifestations in terms of change of color, thickness, and the textural modifications. The first is yes.
Sir, Shrikant sir has joined, and Nazia ma'am has joined. So she's assistant professor from Saptagiri. Hello, sir.
Welcome, Dr. Shrikant, and welcome, Dr. Nazia.
Yeah.
Thank you, ma'am.
Yeah.
Thank you.
Thank you, sir. We will continue.
Srikanth has asked a question. I think she will answer that now. I think, to add to what Dr. Jyotsna said, that WHO keeps on changing the definitions and terminologies.
Correct.
So don't think that is actually done willy-nilly and just because they wanted to do something. What happens is there is accumulation of data over a period of time, and the understanding of each disease keeps changing. So there is usually a consensus conference where they sit down and go through all the current evidence and then come up with the new terminology. So I think it is probably because of better understanding of the condition rather than just they're not doing it at their whim and fancy. I think that is one thing you have to understand. So the definitions keep changing because of the changing disease patterns and also changing understanding of the disease. Correct, Jyotsna?
Yes, sir. True, sir. Very true. So we also need to know how we have come to this stage in terms of like grading, in terms of like new pathogenesis, like theories and everything. It's always good to know that, and it is interesting as well. Like in this case, like how actually there are actually like different definitions of leukoplakia as well, sir. Right now we define it as like this is a whitish lesion which doesn't have any other characteristics of other lesions. Like you have to rule out candidiasis and other things, and then only you can make a diagnosis of leukoplakia. And also histologically also it has greater implications.
Okay, carry on, Einass.
Yes, sir. In terms of genetic and molecular alterations, they are associated with amplifications, deletions, and insertions of DNA sequences of oncogenic factors, like it could be CDKN2A or EGFR or MYC. These are found to be more associated with the oral leukoplakia. And leukoplakia is also associated with DNA ploidy abnormalities, and furthermore there can be positive telomerase activity and loss of heterozygosity, on particularly on 3p or 4q arms of the chromosome. And the most frequently being affected is TP53. There are genetic mutations which are seen, the most frequent of which is TP53, followed by Notch1, FAT1, and also KMT-C is also implicated. There's an immune profile. There's an increased expression of HLA and interleukin 10 and transforming growth factor. Further, there can also be an increased expression of programmed death ligand 1. These have been seen to be associated with oral leukoplakia, contributing to the degree of epithelial dysplasia seen individually. There is also an increased amount of CD8 plus T cells, cytotoxic T cells, and T regulatory cells, which has been seen. But this is more seen in the subtype that is proliferative verrucous leukoplakia. Going to the oral microbes, certain oral dysbiosis in terms of certain microbiomes like Haemophilus leptotrichia, Campylobacter, and Fusobacterium have been associated with leukoplakia, and then for the potential of development of oral squamous cell carcinoma. There are biomarkers associated as well, like we can see DNA hypermethylation, increased expression of microRNAs, and altered expression of P53, which is seen in leukoplakia. Going to the clinical presentation here, basically there are leukoplakia is a white patch of the oral mucosa which cannot be wiped off with a gauze, and it can classically have two forms, that is homogeneous and non-homogeneous leukoplakia, wherein the non-homogeneous form has a higher risk of oral malignancy. The homogeneous leukoplakia presents as uniform white plaques with a regular texture, and they have well-defined margins, whereas non-homogeneous leukoplakia presents with they have a speckled appearance, like a mix of red and white lesions, and somewhat like a presentation of erythroplakia, and they can also be granular or nodular white lesions. The third being proliferative verrucous leukoplakia, which is a rare and a very aggressive form of non-homogeneous leukoplakia, and it is associated with a very high risk of malignant transformation. A few images which are showing leukoplakia as the white patch, which this cannot be wiped off.
1 second. Go back
Yes,
to the
ma'am.
picture.
Yes.
So the first one is, can you explain that? Can be not exactly, that is not exactly a homogeneous, but compared to the second picture, it can
Second
look
one.
like a homogeneous, correct? So both
Yes,
the things
ma'am.
you have named it as leukoplakia. So one is
Leukoplakia.
homogeneous and the other one is
Non-homogeneous.
non-homogeneous. Okay.
Yes, ma'am.
So in the proliferative verrucous leukoplakia, actually it can happen in multiple sites also in the oral cavity. Okay. Do you have a picture of it? No.
No, ma'am, I've not added for proliferative leukoplakia.
This
Yes,
one
ma'am.
borderly comes to the varicose only, the second picture. Okay. So
Yes,
the
ma'am.
non-homogeneous leukoplakia, it will have different textures and colors and the patterns as well. So sometimes there will be erythroplakia patches in between. There will be papular, macular, elevations also. So it is different textures and also it is not uniform. Okay. So
Yes.
just as we have already gotten into the stage of pre-malignant conditions or the potentially malignant, how do you differentiate between this candidiasis and the leukoplakia? Do you have a slide further in this?
Yes, ma'am. I do.
Sure.
So
then we will do that. Okay, no issues.
yes, ma'am. Yes, ma'am. Thank you. Then further going to the diagnosis, first you look at the clinical suspicion, wherein firstly you see a white lesion which is not being wiped off with a gauze. It does not appear to be traumatic or frictional in nature, and it is there are potential etiological risk factors, and also the duration, for a period of 6 weeks. If you see this patch, then there should be a raised suspicion for leukoplakia. Then the definitive diagnosis will require biopsy and histopathology, wherein the histopathologic features will include hyperkeratosis. They can also be parakeratosis, and along with that, there'll be cells which will be showing, some cells showing atrophy with patches of inflammation, and hyperplasia without dysplasia. And if there is a case of varicose hyperplasia, which has a high potential of malignancy, these can be associated with a mild, moderate, or severe grade of dysplasia as well. For differential diagnosis, there are various other patches like frictional keratosis, lichen planus, submucous fibrosis, and candidiasis, which have to be excluded. Herein, basically, you see if there's a white macula or a patch, and it is unilateral, then you will see if there is a recent application of topical drug. If yes, then you consider it like a potential of chemical burn. If no, then you see whether it's on the E. dentalis rich site or any site which is prone to chronic trauma, and the lesion will disappear once the trauma is removed. If yes, then it is possible that it is a frictional keratosis. Further, if no, then you will look for any if the lesion if there are striated lesions or papule. If the striated lesions are present, then it could be early lichen planus. And if no, then again you will look for if there is a central red area which is surrounded by white striations. If yes, then that is discoid lupus, and if no, then again you also look at where it is present, whether it's on the border of the tongue and it is forming parallel patches, then you consider it to be hairy leukoplakia. And if this white macule is not fitting in any other of these clinical conditions, then it will fall into the category of leukoplakia. And if the lesion is bilateral, then again, if it is a simple white gray discoloration and it disappears on stretching, then it is leukoedema. And if there are striae papules, or if they are symmetrically present, then you will consider it to be lichen planus. If no, then you also ask for a family history and also look for a spongy appearance on the surface. If yes, then that is white sponge nevus. If no, then the other thing is you look for features suggestive of fibrosis and limited opening of mouth in if the patient is having areca nut chewing, a habit of areca nut chewing, then in that case you consider it to be submucous fibrosis. And no, if multiple white patchy lesions are present which are not fitting into these conditions, then if it is a varicose lesion persisting with recurring therapy, then you will consider it to be a proliferative varicose leukoplakia. And if no, then that will come in the category of multifocal leukoplakia.
Einass,
Yes, ma'am. Yes, ma'am.
it was a beautiful flow chart. I really wish you had small pictures of each of these conditions so it will imprint in the minds. So, yeah.
Yes, ma'am.
Do you have pictures of this discoid,
No, ma'am.
lichenoid lesions and all that? No?
No, ma'am. Like in the beginning, most of the pictures which I had added was
okay.
yes,
This
ma'am.
is only for the diagnosis.
Yes,
okay.
ma'am.
In the lichen planus, you've said there will be symmetrical striae, right? Do you know of any name which is given to that?
Ma'am, it's that Wickham striae.
Wickham striae. Yeah.
Yes, ma'am.
Yeah. Continue. Continue.
Yes, ma'am. Going to the treatment, you'll focus on there'll be the surgical management and the medical management as well. So basically, the primary aim of leukoplakia treatment is to prevent or decrease the risk of oral squamous cell carcinoma. And in surgical techniques, the removal of oral leukoplakia will include your conventional cold scalpel excision and laser excision, which will involve using lasers of different wavelength, which could be carbon dioxide ND-YAG laser or even the YAG or diode laser, which is available. The photodynamic therapy will use different photosynthesizers, which could be methylene blue or photofrin or even aminolevulinic acid. And these are given at different wavelengths for different duration. And even this has been implicated, but however, there's not a lot of evidence about the therapy as of yet. And medical and complementary therapies include administration of retinoids, vitamin A, NSAIDs, and carotenoids. The use of retinoids and vitamin A is basically because of the effect on epithelial turnover, and NSAIDs have the modulating effect on the specific prostaglandins. That's why they alter the possibility of carcinogenesis. And yes.
Yeah, continue, please. Continue.
Yes, sir. All patients with oral leukoplakia need to be educated about avoiding exposure to the known risk factors of oral cancer, which includes smoking, tobacco, alcohol, and chewing areca nuts. Then further, there's also this flowchart wherein patients with histologically confirmed diagnosis of oral leukoplakia, you will assess the lesion size and location, and further you look for if the lesion is presenting with any one of the following features, which could be dysplasia on histopathology if it is non-homogeneous, or it is located in high-risk areas for oral cancer, which could be the ventral border of the tongue or the floor of the mouth. If yes, and the lesion is less than 3 centimeters, then you consider going ahead with surgical excision or laser excision. And the other thing is you can reassess at 3 months, and you note if there is a recurrent lesion which is noted. If yes, then you will again do a biopsy and again consider treatment options based on what the pathological findings are. If not, then again you do a follow-up every 3 months for 1 year, and then yearly thereafter. If the lesion is more than 3 centimeters, then surgical excision, you do it if it is feasible. And again, clinical follow-up for 3 months, for a year, and then every yearly. And or you can do a clinical follow-up every 3 months and rebiopsy every 12 months to note for any suspicious changes for oral cancer, which could be in the form of ulcerated areas or mucosal hardening. And if all of these features, like the above mentioned features, are not present, then you consider clinical follow-up every 3 to 12 months and rebiopsy if changes are noted.
Just before going to that, also
Yes,
Dr. Shrikant sir has asked a question. What is the incidence of progression to malignancy in leukoplakia? Could you please answer that?
Ma'am, like 20 to 30% is the risk for transformation.
No, not really, not that much. So there's a beautiful paper by Oresta and Thomas. They have actually done a meta-analysis on this. Okay, they have given
Yes,
two different transformation rates: cumulative transformation to malignancy or malignancy transformation rate, and per year transformation rate. In that leukoplakia, they found that only 8.6% of all the lesions will transfer cumulative empty rate. So that is like overall there is only 8.6 percentage. So in other papers, they usually tell from 7 to 11%. Okay. This is a regular leukoplakia. Per annum, they have the risk of 1.56%. So this is in a study. Okay. So
yes,
that was my question earlier. After I saw your slide, I just wanted you to complete it. So when do you actually decide on going ahead with a surgical management or medical management, which you have already explained in the last slide? Okay, so this is the malignant transformation rate. Yeah, please continue.
yes. Then proliferative varicose leukoplakia, it's a rare aggressive form of oral leukoplakia, and again it has a varicose appearance. This will show multifocality, slow growth, and this has a very high rate of malignant transformation. And it initially presents as a single leukoplakic area, which could be on the gingiva, oral mucosa, or tongue. And over time, the lesions will become diffuse, develop, and they could develop exophytic, wart-like erythroplakic areas and transform into squamous cell carcinoma. The diagnosis is again based upon the clinical findings and histopathological features. And further, the proposed diagnostic criteria is for PVL includes that the keratotic lesions could be smooth, fissured, varicose, or erythematic with or without ulceration. They are multifocal, large lesions more than 4 centimeter involving one side, and if there is a single large lesion of more than 3 centimeter involving contiguous sides, and lesions that progress or expand in size and develop multifocality over time. Histopathology can show again the same features of hyperkeratosis, parakeratosis. In addition, atrophy, acanthosis, and cytological atypia may also be seen, and they may be associated with lymphocytic infiltrate. Again, the treatment, there's no curative treatment for PVL, and the multiple therapies for temporary control include surgical excision using the laser ablation techniques, cryotherapy, photodynamic therapy, and radiation therapy. In addition, you also use oral retinoids in the normal conditions, and topical bleomycin has also been implicated in the in the use of PVL management. Further, there is also a nivolumab is a monoclonal antibody, which is it is still under trial, but this has also been implicated in
No,
the management of PVL because they work as an anti-program they work as an anti-program cell death protein, one antibody.
Einass,
Yes, sir.
the word is not indicated, because
And
implicated means it is causing something. It is not. It is used for
yes, sir.
treatment, so it is indicated.
Indeed.
And Jyotsna, one more thing I wanted to ask is, if you excise the leukoplakic lesion either by
Yes, sir.
surgery or laser, what is the chance of it reappearing, or how fast does it reappear?
Yes, sir. This was a question for Einass I wanted to ask. So we have like multifocal leukoplakias and recurrent leukoplakias, or any malignant or pre-malignant condition for that matter. So there is a theory behind it, sir. I just wanted to ask them if any of them know about it. In my last class of the oral cavity cancers, I had explained it to them. Nikita, anyone of you can tell? Pavan?
Pavan is not there.
Not there, is it? Oh, okay.
Pavan is actually left. He's finished his DND.
Oh, okay. I'm not aware of that. Okay, sir.
Yeah.
So basically, there is something called as field cancerization, sir. Field cancerization. So a person can be exposed to the carcinogens, or their like hereditary or genetical abnormality which can be present, which affects large surface of the area. Even though you take out the part, whatever is visible to you, there are still chances of it coming back because the whole mucosa is exposed to that particular carcinogen, or to the genetical abnormality which is already present, or difference in the oral microbiome. So these are the three main causes for the pre-malignant or the cancerous lesions. So there are three ways of this field cancerization, sir. So the field cancerization, first one, it is like by the migration. So in one part it will be there, and the same pathogenesis will migrate to the next part. So that is migration. Next one is independent. So there will be independent pathologies occurring at the same time in different positions. Then the next one is intraepithelial migration, meaning not from the above, but underneath the basement membrane, the bad cells will actually migrate to the opposite side and can cause. So because of this field cancerization, one cannot definitely say that the person will get or not, sir. But high chances, at least compared to the normal person, some 2 to 3 times more chances of getting the same lesion again is there, be it pre-malignant condition or the cancer condition as well.
Cancer. Okay. Carry on.
Carry on, Einass. And yeah, I just wanted to just add to whatever you have said regarding the varicose lesion, proliferative varicose leukoplakia. So it is usually more present in the females, okay, and it is less associated with tobacco usage also, and it is more aggressive. That is something which is interesting here, sir. So we think like, a person who is consuming smoke, like having any carcinogens like nicotine and everything, their chances of malignancy will be higher. So there is this thing that if a non-smoking person or a person who doesn't have any habits happen to have this pre-malignant condition, their chances of turning into malignancy is higher than a person, yes, than a person with habits. So similarly, this proliferative varicose leukoplakia is less associated with tobacco or any other carcinogen. And also the chances of this transforming into malignancy is high, nearly 33%. When you see the regular leukoplakia, it is only like 8, as I told you, 7 to 14% or 7 to 13%, that's all. Whereas your proliferative varicose leukoplakia, it has higher chances of malignancy transformation. And there is a criteria as well, diagnostic criteria. If I'm not wrong, it is called Carrett's criteria. So you will see a minimum size of 3 centimeters of this lesion, and it has to be present for at least 5 years, and availability of at least one biopsy have to be there to prove that it is a proliferative varicose leukoplakia. So these are few points which I wanted to add. Continue, Einass.
The other pre-malignant lesions, that includes erythroplakia. This is relatively uncommon, and it appears as like a fiery red, sharply demarcated patch, which is located most commonly on the floor of the mouth. And after that, like it could be present over the ventral aspect of the tongue, or over the soft palate. And this is generally found more in older patients who are consuming tobacco and alcohol, and therefore it is a high risk of malignant transformation. On histopathological examination, erythroplakia will show dysplasia of variable grade, and sometimes even carcinoma in situ. And less frequently, it can also show features of invasive squamous cell carcinoma. Surgical excision with a clear margin is a common it is a common treatment modality for oral erythroplakia. And yes, you can use again the same laser techniques of carbon dioxide or Nd:YAG lasers can be used for the excision. Then oral submucosal fibrosis. OS, yes.
One second, Einass. So have you read about any differential diagnosis for like oral red lesions, like for example erythroplakia? What all other differential diagnosis can you think of? You've already mentioned it in your earlier slides, like erythematous candidiasis.
Yes, ma'am.
Yes. Okay. And pemphigus
yes,
is
ma'am.
one of them. Okay. Atrophic like lichen planus we have, that is one of them. In few like cases, Kaposi sarcoma can start like this. Okay. So these are the few differential diagnoses you can keep in mind while dealing with the erythroplakia. Again, coming back to the same question, because there is something which is important, like, you need to know the malignancy transformation rate. Okay. Do you know about the percentage of erythroplakia?
Ma'am, I'm not sure, ma'am. Like I read, like annual rate was around 2.7%, but I'm not sure, ma'am, whether it's correct or not.
Okay, it's a little
Yes,
higher.
ma'am.
Okay, as
Yes,
I
ma'am.
was telling you, cumulative malignancy rate is around 33%. Okay,
Yes, ma'am.
and 2.7% is right. That is your annual this one. And the proliferative varicose leukoplakia is around 50%. I confused the other time. So PVL is actually 50% and erythroplakia is 33%. Okay, continue.
Yes, ma'am. Yes. Then actinic cheilitis. This is it is basically a chronic inflammatory condition which is affecting the lip, typically the lower lip, because of sun exposure, and because of this, it's also called solar cheilitis. You also have a submucosal fibrosis, that is a OSMF. This is a chronic progressive pre-malignant condition, and it is characterized by fibrosis involving all of the oral submucosa, and it is again commonly seen in patients who are chewing areca nuts or betel quid, and it is more commonly seen in the southern Asian population. The symptoms can be in the form of burning sensation of the oral mucosa, ulceration, and pain. And this is also followed by atrophic changes, pallor, and induration of the mucosa. This will ultimately result in a marble-like appearance. And fibrosis can also extend posteriorly to involve the soft palate, uvula, and it can also involve the tongue. And if there is a very advanced disease, the patients can have a restriction of mouth opening and difficulty with chewing, speaking, or swallowing. And again, the diagnosis is made first based on the clinical features, and it can be confirmed by the biopsy, which will show the features here, which we can see will be collagen hyalinization, extensive fibrosis, which is extending up to the superficial muscle layer, and blood vessel obliteration as well. The mainstay management is discontinuing the consumption of these carcinogenic products, but there is no specific therapy for OSMF. Treatments that have been include intralesional corticosteroids, hyaluronidase, and collagenase injection, and again, surgery like laser therapy and administration of oral antioxidants have also been implicated. The oral lichen planus and lichenoid lesion.
So you did mention about the medical or the injections, local injections. How long will you give and how often do you give?
Ma'am, you give it for a duration of 6 months, and then you monitor every 6 months, like how whether it is responding or not, and then alter the dosage, ma'am.
Again, do you give it like every day? How is it?
That I'm not sure of that, ma'am.
Usually we give it around 5 to 7 days once. Okay, it is pretty painful procedure actually. Generally, we give it for nearly 12 to 15 weeks initially. Then we see if there is any help or there is any improvement in that. Okay, Again, we ask them to stop all the quid, or the betel nut, aracanut, everything, and we see for the improvement. Now, coming to the surgical, do you know of any surgical treatment for this?
No, ma'am. I haven't read up
Okay.
about
So
that.
few things which you have missed out is grades of it. If you know the grades of it, and you can actually correlate with the treatment given to that. If it is just a regular, the marble like sheets, what you mentioned, it is like that, definitely whatever you said, the submucosal injections will help. Okay. But if it has gone to the fibrosis end, where there is thickened mucosa and the patient is having trismus, there is an inability to open the mouth, then you will have to go and release these bands. Okay. And also there
Yes,
are
ma'am.
few studies which supports submucosal excision itself. The first layer of the mucosa, they usually excise it also. Okay. That is one of the
Yes, ma'am.
treatments. And they do coronoidectomy, these are the parts of mandible, if you know that. Yeah. So as there will
Yes, ma'am.
be bad trismus, the patient won't be able to open the mouth to release the muscles around the coronoid of the mandible. We do coronoidectomy as well. Okay. Especially with patients having carcinoma whom we need to surgically operate, and the patient is having very bad trismus, we do the coronoidectomy first, release the muscles, and then open the mouth wider, and then we go ahead with the excision of the carcinoma. So these are few surgical techniques we use for submucous fibrosis. Okay. Yeah, please
Yes.
continue. That's what. Just read about the grades of submucous fibrosis in the next class. Okay.
Yes, ma'am.
Yeah, continue.
Then oral lichen planus and lichenoid lesions. The presentation, it will present like a lacy-like pattern, white patches, which is known as Wickham striae on the buccal mucosa, and it can extend up to erosions on the gingival margin. That is, like the presentation is that of desquamative gingivitis, and further it can also go to involve the tongue or buccal mucosa, and they are potentially malignant lesions which are associated with the development of oral squamous cell carcinoma. Oral lupus erythematosus is a lesion which includes white plaques. They have sort of a silvery white scarred appearance, and they can also have punched out erosions or ulcers, and which will be surrounded with erythema. The diagnosis will require biopsy, and based upon the histopathological finding, like you'll look for findings of hyperkeratosis, liquefaction of the basal layer, and the presence of like a dermal band-like lichenoid infiltrate may also be seen. These are a few images of erythroplakia, oral, which is being seen at the base of the tongue, oral submucosal fibrosis, which is seen extending near the soft palate and uvula, and the lacy, the Wickham's striae, which are seen in conditions like oral lichen planus. Just to complete, like squamous cell carcinoma, the as already discussed, leukoplakia, erythroplakia, and leukoerythroplakia are the precursors. Further, you'll have squamous hyperplasia. Uh, Basically, the normal oral and pharyngeal mucosa is non-keratinized, and it originates from a single layer of basal cells. And they will mature, and then they will ascend towards the mucosal surface, and they will become larger in size because of cytoplasm which contains keratin. Squamous hyperplasia is a reactive phenomenon which will be basically thickening of the squamous epithelium, and it will include both acanthosis and expansion of the basal cell layer. And this will result in like localized hyperkeratosis, which is classically seen in patients who have a squamous cell carcinoma. The other is a squamous dysplasia, wherein you have pre-malignant proliferation of squamous epithelium, and it affects the mucosal surface of the like basically the upper aerodigestive tract, and it is like this is again a precursor for SCC, and is related to various etiological factors like tobacco use, alcohol consumption, again the same chewing of areca nuts and betel quid. And there are various variants also which are there for like histopathological variants of SCC. The first being well differentiated squamous cell carcinoma. Herein, you can see the keratinizing squamous cell carcinoma, the keratin pearls which can be seen, and well-defined tumor outline is seen with cytoplasmic connections. And further, the next one is
1 second,
yes,
Einass. Sorry for
yes,
this
ma'am.
jumping. So you were just like explaining regarding the dysplasia and everything, no? Can you
Yes,
please tell me the difference between carcinoma in situ and squamous cell carcinoma? What is the difference? And have you heard of a term called as oral epithelial dysplasia? Like you just like, can you go back to the previous slide? You have mentioned about squamous dysplasia, correct? So
yes, ma'am.
there is another term called as oral epithelial dysplasia, OED we call it. And there is a grading also for that. Okay.
Yes, ma'am.
So that actually correlates with the question which I'm asking. What is the difference between carcinoma in situ and squamous cell carcinoma?
Ma'am, carcinoma in situ is like it is an early form of squamous cell, basically restricted to the outer layers, ma'am. It has not extended deeper. Is how you
deeper. So
yes,
for
ma'am.
you to understand that, you just need to have a general idea. In our epithelium, you can again broadly classify it into upper one third, middle one third, and the lower one third, which is a basement. Okay. So this squamous hyperplasia, mild dysplasia, all this happen in the first one third. Okay. One third. So the display plastic changes. The moderate and the severe dysplasia, they will affect your middle one third and a part of the last layer, there is a basement layer. So when it comes to the carcinoma in situ, the full thickness is involved. Almost full thickness architectural disturbances are seen, but it is not breaching the basement membrane. So that is called as carcinoma in situ. Okay. So if it is breaching the basement membrane and it is going beyond to the dermis, then it is called as squamous cell carcinoma, and it is an invasive one. That is why we call it, right, invasive squamous cell carcinoma. And these are pretty aggressive. Okay. Yeah, carry on
Yes,
with the
ma'am.
variants.
Yes, ma'am. The other image being that of focal keratinizing squamous cell carcinoma. This is a moderately differentiated SCC. Here, you can the arrow is showing the focal keratinization, and in addition to that, you can see nest of the tumor cells, basaloid tumor cells, and there is a peripheral palisading as well of the stromal surface, which can be seen. The next poorly differentiated SCC. Here, there are tumor cells present, but there is no keratinization or the intercellular bridges which was seen in the like the previous two images, and there is a background lymphocytic infiltration which can be seen, and for identification of this as SCC, you may require like confirmatory immunostaining for factor cytokeratin P63 or P40. Barring that, there are a few variants like verrucous carcinoma. Herein, you'll have a warty appearance on visual examination, and on microscopy you can see like the elongated fronts of surface growth, and they are usually heavily keratinized. The tumor is intersurface with the underlying connective tissue is pushing and extending below the level of adjacent uninvolved squamous cell mucosa. Then the last one is the spindle cell carcinoma, which is another variant, wherein we can see fascicles or pinwheel arrangements which can be seen. Again, to differentiate spindle cell carcinoma of the head and neck from that of sarcomas or melanomas, you will require immunostains for cytokeratin, which will be useful in the diagnosis. It can be seen in the adjacent slide, cytokeratin immunostaining. Then just to complete, like the risk factors of oral cavity cancers, tobacco products, alcohol, viral infection, which will include HPV, Epstein-Barr virus, And furthermore, it can also use hepatitis C has also been implicated along with herpes simplex virus. Immunodeficiency as seen in HIV, beetle mat chewing, and other risk factors herein radiation, dietary factors, and even like mouthwash, which has high concentration of alcohol, has been implicated as a risk factor for oral cavity cancers. Then going to the clinical features.
I think Einass,
What is
Yes, sir.
8 o'clock now. So I think because have you got many more slides of this, or you will continue it in the next class?
So there are like clinical features, diagnosis, and management is left, sir.
Yeah, then you can't finish that now,
No, sir. No,
obviously.
sir. Yes, sir.
So we'll have to go to the next class, which is Thursday.
Yes, sir.
No, so I think with the Jyotsna, you can any clarifications, doubts, or questions can be answered now.
Yes, sir. I see that there are two questions on the chat. Sir, Shrikant sir has asked, what is the margin for leukoplakia excision and how do you cover the defect following excision? Any answer for that, Einass?
Uh,
What is the margin
and
which you usually do? You have read about the surgical excision of the pre-malignant conditions.
ma'am, like please, you use a margin of around 5 mm for excision, ma'am. Like no,
No,
not
no, no.
that is for
For cancers usually. Sir,
yes, ma'am.
around 3 mm at least for a safer margin, because we do not know the underlying dysplasia of the epithelium. So clinically or like in the practical wise, we usually leave at least 3 to 4 mm margins. We take one margin around 3 mm. And coming to the covering part, as it is just a mucosal excision, we don't have to cover anything when it comes to the tongue or the buccal mucosa. In case we have gone a little deeper during the excision or because we felt that the lesion is going beyond, then we can always cover it with buccal pad of mucosa if it is in buccal mucosa lesion, or we can always take the nearby lesions, sir, nearby flaps. Sometimes few surgeons, they also cover it with split thickness, skin thickness, skin graft as well. That is one of the options, but not done anymore. So these are the few ways we actually cover up the lesion. Any other questions regarding the potentially malignant conditions for today?
I think Einass has comment. I'll invite comments from the students first,
Yes.
and then Srikanth and Jyotsna.
Yes, I think she's done a good job explaining everything, sir. I only wish the pictures were next to the description so that people can see what she's talking about.
Yeah.
Apart from that, it was a good, nice descriptive presentation, Einass. Congrats on that. Yes, we can cover the cancer part in the next class.
Next class. Srikanth.
Good presentation. Well done.
Students, anybody? I think at least make a comment, man. You are all just sitting there and listening. Either she has done a very good job or she has not made any impression on you.
Sir, she has done a good job, sir. That vast, brief explanations of all the points. Like, yes, sir.
I think Einass has done a very good job. It's a difficult class, and I think the flow chart was she did a very good job on flow chart, and I agree with Jyotsna. I think it is difficult, but if you could put pictures along with that, then it would have been better. But I think ultimately you have to say she's done a very good job of this class. Hopefully she'll continue in the next class. Thank you.
I agree, sir. Thank you, sir. Thank you so much. Thank you all. Good night.